Hi guys, how are you?
Oh, hello.
Hi Sergey, how's it going?
Hello. Nice to see you.
It's pleasure to see you again.
Yeah.
Tenoch, it's pleasure to see you there as well.
Yeah. Today, as you can see, there is a large Russian-speaking, so I mean from Russia, a lot of participants.
I'm so happy that they're joining early. This is very good for us.
Yes, these days we have our national course for pediatric neurosurgery, and I invited all my participants to this course, so I hope that they will enjoy it.
I'm sure everybody will enjoy that. Is Abhaya here as well? I'll just see if I can unmute him.
Yes, yeah, I'm here.
Oh,
Hi, Abhaya, good to see you.
How are you?
Pleasure seeing you again. How's everything?
Too. Things are well, yeah, thank you.
Everything okay in Canada at the moment?
It is, yeah, it's not bad. It's the COVID situation is regional, so in Toronto we've got more of it than other places in Canada, but it's still under control, I think, relatively.
Okay, brilliant. Hi, Tenoch, how are you? Can you hear? I think trying to unmute you. Just 1 second.
Yeah, I think the same as Russia. We are on the plateau in general in the country, but in Moscow the situation is rapidly improving. So we open more and more facilities for the common people. So I think that the end is clearly seen, I hope.
Yeah, what's happening in many places is the second wave question is a problem. So I think people should not put their guard down. I think it's important. What's happening in many places is what, you know, in Brazil, for example, in US, in some places it's bothering them. We are still up on the rise, but you know, we are up to about 70, 80 deaths a day at the moment. So it's not as bad, but still, you know, it's quite bad for our system. Let's see, Schlomi is here, so let's unmute.
Yeah.
There we are.
Yeah.
Hi,
Schlomi.
gentlemen.
Henry, how are you, man?
Hello.
Hi, good to see you. I had a severe problem with my wireless. I don't know what it is. It's very, very bad connection.
It's
This is
German, man.
Typical East Germany still.
Henry, did you say you had problems with your wife or with your wireless?
Both.
In my village house, the Wi-Fi is excellent.
Welcome, Schlomi. How are you?
Surviving.
Very good. How's the situation in Israel?
Well, we have the, you know, for some obscure reason, the Middle East has been suffering from so many wars and problems, but Israel, Cyprus, Greece, and the West Bank and Gaza, which is probably the most populated place in the world, have been secure. The reason is I cannot figure it out.
Okay, that's brilliant. And as long as you have it, you know, let's quietly take it.
I think God is making balances, you know.
Yeah. You're right. I think it's 5 o'clock. Is Moody here somewhere? Let's just check if he's coming. No, Moody hasn't checked in yet. And I don't see the Pujari as well.
Yes, they're not here.
Yeah.
Hello, I am here.
Okay.
Okay. Henry, shall we start? Because it's 5 o'clock and I don't see, let me see if they have sent any message. No messages yet. Let me just send a quick message. He's online, so he should connect. I think we'll start and take it from there. Welcome again. I think it's our 5th webinar for IFNE and WFNS Endoscopy Committee. You know, all of them have been great up till now, and the future ones are actually more mouth-watering. The one today has got excellent lineup, and I'm grateful to Henry for choosing and selecting people who have been brilliant, and you know, you have learned so much from them. So we're going to start this with a famous name who's done so much for us and has done lots of interesting papers for us, lots of interesting work, which has really become milestone of our day-to-day work. So I'd invite Abhaya Kulkarni to start his talk, and this will be on, you know, we are talking about ETVs today, and his talk is going to be basically, it's going to set it up how we're going to go about it throughout this webinar. Abhaya, all yours.
All right. Thank you very much. There. I'm going to try to share this.
Yep.
Okay. Can you see?
Yes.
Okay. Thank you. Well, thank you very much for including me in this. It's really nice to see everybody remotely. It's nice to keep these connections despite our isolation these days. So thank you very much. So I'm going to talk about ETV with choroid plexus cauterization and just review where we currently stand with this, review some of the history of it, and where we might be going future-wise. So I'll start with the early history of ETV and CPC, which was really the history of the choroid plexus as the target of hydrocephalus treatment. And obviously, most people in this audience will know that targeting the choroid plexus for hydrocephalus treatment is actually very old. So it's over a century old. And these are just some of the big names in neurosurgery and beyond who tried this. And they did it in different ways, either through coagulating the choroid plexus, or actually in some cases, in the case of Dandy, trying to do choroid plexectomy. Back in those times, however, the procedure was not terribly successful. They were limited by their technology, the optics that they had, and the anesthetic issues. So you can see here from the 1940s some examples of series in which they tried to remove choroid plexus, and you're looking at operative mortalities of 43, 46%, right? It's incredible to think about that these days, but it wasn't a great treatment for the technological reasons that they had then, but it was really one of the only treatments for hydrocephalus until the shunts came. And then by the time the shunts came in sort of the latter half of the last century, then CPC really fell by the wayside, because the morbidity and mortality comparing the two was really not comparable, and shunts were clearly a better way to treat hydrocephalus. Now, there were some centers that were still carrying on with versions of CPC for limited indications, particularly in New York and in Bristol, but for the most, it was not a mainstream procedure at all. And then the revival, which started in Uganda with Ben Whorf, and I think most people here know his story, that he went to Mbale, Uganda, at a hospital there where the primary condition he was treating was infant hydrocephalus. He had issues with access to and complications of shunting and was looking for alternatives. He was given a flexible endoscope and started doing ETV, and then decided, I think pretty much on a whim, recognizing that 100 years ago people were cauterizing choroid plexus, that maybe he'll try that in addition to doing the ETV. And so he combined these two procedures, the ETV with choroid plexus cauterization, using a flexible endoscope, single coronal entry site, accessing both lateral ventricles, and performing a septum pellucidotomy when required. And then he published his first paper, a really seminal landmark paper, in 2005. And since then, we've learned a lot about what this procedure can do. For those of you who haven't seen it, this is what it kind of looks like. So through a flexible endoscope, this is cauterizing the, This is cauterizing the choroid plexus in the body of the left lateral ventricle. This is a monopolar cautery. And you just run along the choroid plexus, as I've shown here, changing what's pink to white. So you're just blanching the choroid plexus along its entire length. So you do this for both bodies. You do a septum pellucidotomy when required to get into the contralateral ventricle. And then you take the flexible endoscope into the temporal horns as well. And ultimately what you want to see, this is at the end of the case, this blanched choroid plexus. So what was pink is now a strand of white. And this is the septum pellucidotomy that was created. And if you go to the other side, you'll see a similar band of white blanched choroid plexus there in place of what was usually robust and pink. So that's what you're aiming for. And it takes a while to do it. I think people like Dr. Whorf, of course, are extremely facile in it, having done so many thousands of these. But if you're not used to it, it can take a while to accomplish this procedure. What we learned from the Uganda experience, there was a lot. And what it showed is that, at least in Uganda, choroid plexus cauterization seems to improve the chances of ETV success in a wide range of hydrocephalus etiologies: myelomeningocele, Ugandan post-infectious hydrocephalus, congenital idiopathic hydrocephalus, congenital aqueductal stenosis. The other thing that they found was that CPC appears to have a dose-response effect on ETV success, which I think is actually really important. This was important finding for me when I first discovered this, is when I really first started to believe that there may be some true value to CPC, because if you do a complete choroid plexus cauterization, the chances of ETV success are higher than if you do a partial choroid plexus cauterization, which is higher than if you did no choroid plexus cauterization. And the work in Uganda also showed that if you do fail your ETV CPC and then you have to have a shunt inserted, the survival characteristics of that shunt are not any better or worse than if you'd placed the shunt as the first procedure. And all of that led to set the stage for the randomized trial that we did in Uganda, which was really landmark because it was the first time that this procedure was compared to shunt in a prospective randomized setting. It was a limited group of patients, so these were patients under 6 months of age with post-infectious hydrocephalus. And I just want to comment for those who haven't been to Uganda or seen what post-infectious hydrocephalus looks like in sub-Saharan Africa. It is a different condition, really, than what we would see in North America, and I expect what people would see in Europe and some other parts of the world. So when we say post-infectious here, I don't take this data to be applicable to the post-infectious patients that I would see in Toronto. But so that's just a caveat to this, which I'll get into later. But these patients were randomized 1-to-1 to have either ETV+CPC or ventriculoperitoneal shunt. We identified and randomized 100 eligible patients who were followed. And we published the primary results back in late 2017. And what it showed is that although numerically there was a slight survival advantage to failure advantage to ventriculoperitoneal shunt over ETV+CPC, it was not statistically significant. But more important was the primary outcome. What we were really looking at here was the cognitive outcome. And at 1 year after treatment, there was no statistical difference between either of these treatments. And this was the primary analysis, but when we did a number of other secondary analyses, including instead of doing intention to treat, we did treatment as received. We looked at all the other cognitive scores and developmental scores. We looked at changes from baseline. None of these were different statistically between ETV+CPC or shunt. What was interesting though here, we also looked at brain and CSF volume. And as you might expect, shunt was able to significantly reduce CSF volume much better than ETV+CPC. And this fits with everything we know about endoscopic treatment of hydrocephalus if the ventricles stay large. But what we wanted to look at here more specifically was brain volume. And what we found is that despite the fact that you have more CSF and larger ventricles with after treatment with ETV+CPC, your brain volume is actually not statistically different between the two. And the proportion of patients who actually achieved a normal brain volume was very similar between these two procedures. And these are just graphical examples of that. So you can see here at the top are patients who pre and post treatment went from having subnormal after treatment having normal brain volumes. And then at the bottom, these are patients pre and post-op who did not do that, they failed to achieve normal brain volume. And you can see that any of these situations can happen with either large or small ventricles, that really isn't the factor here, that the brain volume can change independent of ventricle size, which I think is important for those of us who are proponents and want to advocate for endoscopic treatment, that having large ventricles in and of itself doesn't necessarily indicate that the brain volume is suffering. And why that's important is that this study indicated that brain volume was important to not just how it looked on CT imaging, but that it was associated with cognitive outcome. Normal brain volume is associated with higher Bayley scores. Having substantial growth in brain volume was important. You had better scores then as well. And it was a positive correlation between brain volume and all of the Bayley scores, all of the neurodevelopmental scores. A positive correlation, and no correlation was seen with CSF volume. So if you were expecting to see a negative correlation with that higher CSF volume, bigger ventricles was associated with worse developmental outcome, that was not seen. Okay, whereas larger brain volume was associated with better developmental outcomes. That was, I think, a very crucial finding. That was the 1 year outcomes. We've since done the 2 year outcomes. The results haven't been published yet, so I'm showing you something that is not yet being peer reviewed, but the results are essentially very similar. The failure curves look similar. The brain volume again was associated with cognitive scores were again associated with brain volume, but not with CSF volume. What we did find, however, is that the brain growth, which we saw in that first year after treatment, seemed to stagnate in the second year. We don't have an explanation for this, but it was quite worrisome. We were expecting to see these brain volume curves continue to grow and follow normal curves, but in fact, they started to stagnate. They weren't losing brain volume, but they weren't gaining it at the rate one would expect for an infant or toddler of their age. And we don't know why that happened. Now, this study has several limitations, right? So the ability, particularly to generalize this to most of our practices, I think is very limited. So I take this study, I think, has serious implications for Uganda and sub-Saharan Africa and other places in the world that see a similar type of hydrocephalus, but it represents a particular type of post-infectious hydrocephalus where there's substantial underlying pre-existing brain injury, where their outcome overall is quite poor. Those Bailey scores that I showed are very low. And this is just one center in sub-Saharan Africa. And beyond that, measuring cognitive outcome in infants, even though we were using the gold standard, is challenging. And we, of course, do intend to follow this cohort longer. We've already got the 2-year outcomes that I showed you, but we will continue to follow this cohort to age 5 and hopefully provide even more granular, robust data. But the implications of this suggest that brain volume appears to be a more important determinant of outcome, of cognitive outcome, than CSF volume, and raises the question whether we should be titrating our treatment to maximizing brain growth rather than fixating on ventricle size and how large or small the ventricles are. And if that's the case, what's important to know is that at least in this study, we show that both procedures, ETV+CPC and shunt, appear both capable of allowing similar amounts of brain volume growth, irrespective of the differences in ventricle size. So that's a summary of what's happened in Uganda. I think that's important because it set the stage for this procedure to gain traction and some interest in North America, at least. And I'm going to summarize North America exposure here, not to exclude the rest of the world, but I think this is where a lot of the secondary interest outside of sub-Saharan Africa has been, at least from a literature perspective. Just anecdotally and from the literature, my sense is there's much less interest in certainly Europe and maybe other parts of the world. I think in South America, there's also some interest in this. But I'll summarize what we have from North America. So obviously, Ben Whorf was the originator of this procedure. And so when he went back to Boston, we were very eager to see what his North American experience in Boston would show. This is his 2014 series. This was a group of patients who had a mixed etiology of hydrocephalus. And 57% of them were treated successfully on first go, not needing any further treatment, and about 65% ultimately were shunt-free after having had a reoperation. He identified several predictors of failure, and the overall 6-month success rate was 59%, which is about 15% higher roughly than what you would expect from the ETV success score, which, if you take that at face value, suggests that 15% additional success was brought by CPC over just the ETV. And this is what his survival curve looked like, and this is where the ETV success score would have predicted the success rate should have been, but it was instead up here. This is not statistically legitimate to do, but just for fun and comparison, this is what the shunt survival curve from the Hydrocephalus Clinical Research Network would look like for infants with shunted hydrocephalus. So it's not that dissimilar. So his results were actually quite promising. But what's interesting is that there's really a dichotomy of the results. So it's not just infant hydrocephalus. At 6 months, there's a big divide here, with the over 6-month group doing tremendously well, almost 80% success, and those under 6 months doing quite poorly, under 40% success. And you can see the difference there with shunted patients. So his more recent experience is shown here, and this hasn't been published yet, as far as I know. I think it's still under peer review. It may be near publication by now, but this was presented at the pediatric section not long ago, and this is now 215 patients in Boston. And he was looking at all patients all infants that were treated with hydrocephalus, and you can see 215 were presented with were treated with ETV+CPC, 73 with shunt, and 19 with ETV alone. So you can see this is important to know, because this shows what his practice is, right? I think this would be quite different from many of our practices to do this, but it represents what he sees. And likely, I think that the referral bias of patients that come to him looking for this procedure. But if you look at the etiology, it's a fairly standard mix for what we see in North America. Post hemorrhagic hydrocephalus of prematurity, myelomeningocele aqueductal stenosis as the big group. And 68% of them were under 6 months. So a very typical infant North American hydrocephalus population. What he found is that the predictors for reoperation was a young age. So he found at this stage it was under 4 months, prior history of CSF diversion, and a lower Uganda score. So we have the ETV success score, but we also created a few years ago the Uganda ETV success score, which looked specifically at the Ugandan population and included the degree of choroid plexus cauterization in the score. And they found that this score was also predictive of success in Boston. And this is the survival curve that he presented at the last pediatric section meeting. And you can see that the overall success rate for ETV, not needing any repeat surgery, was around 50%. But he was able to get that up to 69 by doing repeat surgery on some of them to avoid a shunt. And this shows quite nicely here, compared to the shunted patients, how the survival curves sort of follow along, and then by about 2 years, you start to see more shunt failures than you see ETV failures. And this is where you start to see the real benefit of this procedure. So looking at his data, the results are actually very promising in North America. But other groups have been doing this as well. And so the Miami group is another one that's been doing this procedure for well over a decade now. They're interesting to study because their technique differs from what Ben Warf is doing, in that they use a rigid endoscope rather than Ben Warf's flexible endoscope technique, which means that you likely can't get as much choroid plexus cauterization, particularly in the temporal horns bilaterally. So, you know, their overall results look less promising than Boston, and the question was why. And so one of our former residents, Shelley Wang, who's now on faculty in Miami, actually, where she did her fellowship, she compared these two series, and you can see here that the rigid endoscope series, which is the Miami series, fared less well than Ben's Harvard series. And if you look at it in an unadjusted analysis, what you found is, yeah, it's statistically true that they do worse off. But once you adjust for patient factors like age, sex, etiology, prior CSF diversion, the presence of prepontine scarring, once you include those in the model, then the difference is not very significant. So it may be that it's not the technique difference or the surgeon difference isn't what's driving this difference, but rather it's the patient selection that's making the difference there. So we've also looked at this in the context of the Hydrocephalus Clinical Research Network. For those of you who don't know, this is a collaboration of 14 centers across the US and Canada. And we do a lot of prospective collaborative hydrocephalus research studies. And just to show you, this shows the number of ETV+CPC cases we did in the early stages of ETV+CPC in North America, going from 2006 to 2014. And you can see the number. So we started in 2006 because 2005 is when Ben published his Ugandan experience, and when we all first started thinking about ETV+CPC. So in 2006, 7, 8, 9, 10, we had very few procedures. 2011 started getting more interest, 2012 more, and then 13, 14 is when we really started to see the inflection point here, and a lot of patients being done. And since then, across the HCRN, we've been doing over 90 cases a year of this. So it's really taken hold as as not the primary procedure for infant hydrocephalus by any means, but certainly what's seen as a viable option procedure for many of our patients. And this is one of the studies that we did looking at it. This was a prospective study of ETV+CPC. And we did this with the idea that we were going to ultimately do a randomized trial. So the purpose of doing this prospective study wasn't just to do a prospective study, but was to gather more information to help us create and design a better randomized trial. And one of the things we did in preparation for that was, Dr. Warf has shown and others have shown that the extent of choroid plexus cauterization is important, but we had no way of reliably quantifying how much choroid plexus is cauterized. We just relied on the surgeon guessing at the end, yeah, you know, I did 70%, 80%, 90%, 95%, et cetera. So we devised sort of a schematic that the surgeon would complete right after surgery to indicate how much of the choroid plexus they cauterized, and then we use that to create a nice, reliable, quantified measure. So these were the patients. There were 118 patients in this prospective series. And again, I want to stress this does not, Dr. Warf is not part of this. And I say that because it's important to see how generalizable these results are. And how does this procedure perform in the hands of somebody other than the person who discovered it and invented it. So 118 patients, fairly typical group, you know, most again, like Dr. Warf's series, were under 6 months of age, and the breakdown of myelomeningocele, IVH of prematurity, aqueductal stenosis, roughly a third each, again, very typical of a North American population. If you look at the ETV success score distribution for this population, not surprisingly, these weren't great candidates for ETV. So they had low to moderate success of their predicted success for ETV. The estimated choroid plexus cauterization that was done by the surgeon, ideally, we want to get over 90%, and in about 3/4 of the cases, 75% of those, we were able to do that. Dr. Worf would have a higher number here. So this was at a stage where a lot of us were still learning the procedure. So this represents our early experiences in gaining understanding and not just of the indications of the procedure, but some of the technical aspects of this procedure as well. So I think keep that in mind as you look at the results. One of the things that was that I found striking with this in terms of the complications was the rate of seizures, a 5% rate of seizures, and this has been quite troublesome to me. I'm a little bothered by this. I think this is fairly high. Again, this is an infant population. These are fairly long endoscopic procedures. So there's reasons one can postulate that why they might have a higher risk of seizures. And I've had a couple of patients that have had postoperative seizures. None of them have been long-term to date. They've temporarily been on anti-epileptics and have been able to be weaned off, but certainly we don't know what's going to happen long-term and whether they will develop epilepsy as they age, which is very important because of all the prior studies I did on quality of life in pediatric hydrocephalus, one of the strongest, most important predictors of quality of life is the presence of seizures. So if you have seizures, you do much worse in terms of your quality of life. So I'm still worried about that factor. This was our time to treatment failure, and you can see here it dips quite significantly down to under 40% ultimate success rate. We looked at the predictors of success, young age. Actually, ventricle size here was important. So larger ventricles was associated with worse outcome. The degree of choroid plexus cauterization was, again, important as a positive predictor. And then visualization of the naked basilar artery, which is really indicative of being able to do a good, thorough endoscopic through-ventriculostomy, a nice fenestration, and clearing all the prepontine membranes. This is not randomized data that I'm showing you here. This is a matched historical comparison to shunts, and you can see that there's quite a difference here. Now, again, there's a lot of caveats with this. It's not randomized, and there was a lot of patient selection bias, I think, in the patients that we treated, and it represents our early experience. So there were a lot of technical factors in how the ETV+CPC was done, I think. So from that, we were still at a stage where we had a lot of data from the HCRN, and that helped us formulate a bit better the patients that we should be targeting for this. So things have been continuing to evolve. And based on the data that we have, which is now several hundred patients, we've looked at the results in these. And this isn't formalized, but this is a sort of our rough approach to these patients right now within the Hydrocephalus Clinical Research Network in North America, that we consider offering ETV+CPC to this group of patients: myelomeningocele patients who are at least term age or above, patients with intraventricular hemorrhage or prematurity who are at least 6 months corrected age or above. And as you can imagine, that's an extremely rare group of patients, right? Most of the patients with preemie-IVH develop hydrocephalus as premature infants, of course. We usually treat with them some temporizing procedure, but then ultimately they get shunted by term age or so. So to have a child who's carried on to being 6 months corrected age and who still has not had definitive treatment for hydrocephalus is quite rare. So it's a very limited indication in our minds. And the reason, again, for that is because we found a very low success rate if you do this in younger patients with preemie-IVH. Post-infectious hydrocephalus, they do very poorly, and we don't do those either. And as I mentioned here, that's different than the post-infectious hydrocephalus in Uganda, which was actually the inclusion criteria for the randomized trial in Uganda. Here in North America, or at least within our network, we tend to avoid doing them in post-infectious cases. And then for the other broad categories of infant hydrocephalus that we see, generally, we'd like to wait till they're at least a month of corrected age before offering this procedure. But in addition to that, those etiology and age limitations, we also obviously want to see favorable third ventricular anatomy that would allow you to perform a safe ETV, and no obvious adhesions in the prepontine cistern on CIS or Fiesta MRI. So all of these patients, I think, do mandate a high quality MR imaging with these types of images preoperatively in the sagittal plane. And I think what's also important is that we try to have these cases reviewed by an expert panel. So the other benefit of having this network is that whenever we have a case like this, we send the cases around to the other surgeons, and they all look at it independently and say yes or no whether they agree that ETV+CPC would be an option here before we offer it to the family. And also, we're doing this in the context of a research study. So I'm going to tell you about a randomized trial that we're doing in a second, but outside of that randomized trial, all these patients are entered in a prospective database. And so they will be part of a research study that we will analyze on a regular basis to learn more about the limitations of this procedure. So that still leaves a lot of questions about ETV+CPC in North America setting here. And these are just some I mean, there's lots of questions you could ask, but I think some of the more important ones is there a minimum age under which the success rate is too low to even offer this procedure? Is it under 1 or 3 months? And I think from the criteria that I showed you before, our answer is that it depends both on the age and the etiology, the combination of those two things. And on the flip side, you know, are there certain etiologies for which it's not useful, like post-infectious hydrocephalus? We think that is the case. And there are certain etiologies for which CPC adds very little. And I don't know if Schlomi's going to talk in his talk about the IIHS study, which I think he will. But based on that, you know, I question whether we should be adding CPC to older children older infants who have aqueductal stenosis, because the IIHS results were so good for ETV alone that I don't think it's worth the morbidity of adding CPC for it. And this question really I find difficult to deal with, which is how low a success rate are parents willing to tolerate for the possibility of shunt freedom? And this is the realities of practice. You know, you'll have families that will come and say that they want this procedure, and I'll have a very long discussion with them. And most of these families are very sophisticated. They will often come, and they will come with my papers in hand and show me and you know, ask me questions about the research, and then they'll say, yes, they want ETV+CPC, and I'll tell them, but you know, your child is in a very poor prognostic category for ETV+CPC. The success rate is only 20% or 30% or something. And they say, yes, we understand that, but we still want the procedure. And, you know, I struggle with what the right thing to do in those circumstances is, because are the parents being unfairly biased against shunt? Because a lot of the information they're getting is from social media, where I think it's disproportionately inhabited by people who've had extremes of outcomes, particularly as it relates to shunt. So heading forward, this is where we're at now within the HCRN. We have been trying for the last 6 years really to have a randomized trial funded to compare ETV+CPC to shunt in North America. Last year, we finally got funding from the National Institutes of Health, and you can see why it was so hard to get that funding. This is a very expensive study, $10 million US. It's going to be a 7-year multi-center RCT across the Hydrocephalus Clinical Research Network. We are we were just about to start enrollment when COVID hit. And so that's delayed things. So some centers are just about starting to recruit now as they're opening up and they're being allowed to participate in research, but that's obviously going to slow things down for us. But it's a long study. We're looking at infants under 24 months of age. We're excluding preemie IVH here. I won't get into the details of why here, but if we wanted to ask that later, we can. And the primary outcome, just like in the Uganda study, will be cognitive outcome at 12 months. But for all the reasons that I mentioned, I think our more important outcomes are going to come at 5 years. We're going to continue to follow this cohort for until age 5 with cognitive, not just cognitive outcome, but quality of life outcome, detailed imaging outcome, including diffusion tensor, MRI, and with CSF biomarkers. So this is going to be a very comprehensive study that, irrespective of the ETV+CPC versus shunt aspect of it, I think is going to give us extremely powerful prospective data on infant hydrocephalus in general. So recruitment is just starting. So I'll ask you all to stay tuned and see what the results are. So sorry, I'm just having a little computer problem there. So my computer seems to be dying. So if I end if I go off screen for a second, I apologize, but I'll try to get back on.
Thank you, Abhaya. That was a brilliant talk. I think we all loved it. I think in the interest of time, what we're going to do is we're going to finish all the 3 talks and come back to the questions, because unfortunately we have already ran out of time. It's already 35 minutes into it. Moody was having difficulty joining in because of some Wi-Fi issues. Someone else, Moody, joined in, who we made a host for a time, for a little time, okay. And then we realized it's not the same Moody. Oh, Moody's here. Hey.
I'm here, Salman.
Yeah. Finally.
Yeah.
Okay.
Yeah.
You want to introduce Tenoch and we get on with it from here? Then we can have questions at the end.
You go ahead and I'll introduce Schlomi then. Yeah.
Okay. So it's really, I think after that fantastic talk, that's really have got the whole thing going for us. I think the talk was brilliant. Everything Abhaya has laid down for us is brilliant. We're going to have for difficult perforation, difficult perforation ETV is going to be by Tenoch, and he is, we're just going to unmute you. Tenoch, are you there? Can you hear me?
Yes, hello. I'm here.
Brilliant. Can you share your slides?
Yes.
Okay, we can see them, fine.
Okay. Hello, everyone, and thank you all, Professor Schroeder and Professor Sharif, for the opportunity to be here. I work in Mexico in the ABC Hospital, the Neurological Center, and I am part of the Latin American study group of Neuroendoscopy. So we will talk about the endoscopic third ventriculostomy, difficult floor perforation. As you all know, and you see in this brilliant exposition by Dr. Kulkarni, endoscopic third ventriculostomy is a well-established method in the treatment of some forms of hydrocephalus. However, it's associated with some serious complications, and the morbidity, it's about 0 to 31%, depending on the city that you consult. The overall morbidity rate is 8.6%, and there is a 2.3% of permanent morbidity, and there is 1% of mortality. So this is not a free of complications procedure. And the most dangerous step in third ventriculostomy is the perforation of the third ventricle floor. The objective of the third ventriculostomy is to establish a physiologic circulation of the CSF. In order to keep this, we fenestrate the premammillary membrane to have a pulsatile beat of the third ventricle floor and to watch a basilar free of arachnoidal adhesions. So in order to keep this, we approach the lateral ventricle, we advance the endoscope into the third ventricle, and visualize the floor of the third ventricle, and then we perform the perforation. However, some pathologies like myelomeningocele, posterior fossa tumors, loculated hydrocephalus, ventriculitis, basal ganglia tumors, thalamic tumors are associated with alteration of the normal anatomy of the third ventricle, and this makes very difficult in some occasions to perform the third ventriculostomy. The anatomical alteration that we can find, it's the thick and prominent massa intermedia. This is most frequent associated with myelomeningocele, opaque or thick floor, and in some occasions we can also have some vascular structures in the floor, the steep down third ventricle floor, also associated with myelomeningocele, or the existence of adhesions or ridges among the mammillary bodies. This makes the risk of penetration to harm the pituitary, the mammillary bodies, the brainstem, the hypothalamus, and of course to harm the basilar artery, which brings uncontrollable bleeding.
There is a study that shows that there is an area between the infundibulum and the mammillary bodies composed of glial cells only in this place that has the shape of a trapezoid. And in this area, the inner and outer surfaces of the third ventricle were covered with ependymal cells and arachnoid cells respectively. This is an area trapezoid in shape as we show here. And the thinnest part of the floor of the third ventricle is the posterior third of the line between the infundibulum and the mammillary bodies. This should be here. And this is the area where the third ventriculostomy should be performed whenever it is possible, but we will see there are some complications when we have anatomic alterations. If we perform the perforation of the floor of the third ventricle too anteriorly, we can have syndrome, some endocrine alteration like diabetes insipidus, inappropriate antidiuretic hormone syndrome, secondary amenorrhea, cardiac arrhythmia, or thermoregulatory disorders. On the other hand, if we have this perforation too posteriorly, we can have memory disorders, personality disorders, or cardiac arrhythmia. And it's very important, the preoperative planning. So to avoid vascular complications, it's necessary a careful evaluation of an MRI in the mid-sagittal plane to determine the localization of the tip of the basilar artery and the thickness of the floor of the third ventricle, and also the orientation of the floor. So in this case, this is a patient that was operated of a posterior fossa tumor. As you can see here, it was removed, but he had a posterior hydrocephalus after the surgery. So we decided to perform the third ventriculostomy. And here in the midline, we can see the tip of the basilar artery and the trunk of the basilar artery, almost occluding the area where we will perform the third ventriculostomy. So in this case, we need to perform the perforation of the floor a little bit paramedian. So we will start with the procedure. In the usual way, we approach the lateral ventricle, as we can see here. Here we have in the lateral ventricle, the usual anatomical landmarks. We approach the third ventricle. We can see here the tip of the basilar artery, and here the trunk of the basilar artery. So if we perform here in the middle line, the perforation, most likely we will harm the basilar artery. So we choose this area to perform the fenestration of the floor of the third ventricle. So we introduce the catheter here, and we start with the inflation and deflation maneuver in order to enlarge the perforation. And once we enlarge the perforation, we have the perforation made, we introduce the tip of the endoscope in order to see if there is no remaining arachnoid in the interpeduncular system. So in this way, we can see the basilar free of arachnoid adhesions. Here we have the flapping, the beating floor of the third ventricle and the naked basilar. In this other case, this is more difficult because this patient has a posterior fossa tumor. As you can see, the brainstem is pushed forward and upwards. So the orientation of the third ventricle is downwards in this here. And here is the tip of the basilar artery. So the space, again, it's very narrow in front of the basilar artery to perform the third ventriculostomy. In this case as well, we perform the third ventriculostomy in the usual way. And we start here with the approach of the third ventricle. And as you can see here, how the mammillary bodies are very prominent, are pushed upwards. So here is the infundibulum, and leaves a very small space here to perform the, in front of the basilar artery, the perforation. So we decided to do it again, paramedium, to avoid any complication with the lesion of the basilar artery. So we start doing the perforation in the usual way, as we can see here. We will introduce the balloon catheter here, and we will start to push the floor of the third ventricle. And this is a balloon catheter without the wire guide, so it's very soft. There we perform the fenestration, and we will enlarge with the tip of the catheter. Again, once we achieve the enlargement of the stomach, now we will advance the tip of the endoscope into the interpeduncular cistern to see that there is no remaining arachnoid adhesions. So to assure there is a complete and free circulation of CSF into the subarachnoid space. As you can see here, here is the trunk of the basilar artery, which is free of arachnoid adhesions. This is very important in order to have a good result after in the control of hydrocephalus. Sometimes there is a little bit of bleeding in the margins of the membrane, and this is so always with irrigation of the Ringer solution, we control this bleeding with no need to bipolar cauterization. And now, another example. This is a different one. This is a patient with hydrocephalus associated with myelomeningocele. And as you can see here, the floor of the third ventricle is typical of the patient with the myelomeningocele. This is an interthalamic adhesion. And you can see there is a step down orientation of the floor of the third ventricle. And we will start with introducing the balloon catheter, but in this case, what we found is that the orientation of the floor was very difficult for us to do the perforation. When we introduce the balloon catheter, it slips into the stalk of the pituitary here into the infundibulum. So we decided to do the perforation with another instrument. Let me show you a little bit here. We introduce the catheter and it slips into the infundibulum. So we decided to perform with another instrument. We always we don't like to use any energy source, not bipolar or monopolar. So in this case, we use the biopsy needle that it's with Orset. As you will see here, there. We did the perforation with the biopsy needle. The perforation is done. Now we will advance the tip of the catheter, the balloon catheter, to do the enlargement with the inflation-deflation maneuver. So now we will, once we perform and did the the fenestration, as you will see here. Now we are going to advance the endoscope here. We are completing the enlargement of the fenestration, and now we will advance the tip of the endoscope into the interpeduncular cistern. And in this patient, especially in this patient, we found that there was still the Lillquist membrane here, and it was not possible to perforate with the tip of the endoscope. So we will again introduce the balloon catheter in order to perform a tear in the arachnoid and then perforate the membrane of Lillquist. In this particular patient, we lean the tip of the balloon catheter against the dorsum sella in order to have a more secure perforation of the membrane and avoid any bleeding complication. Here we will see how we advance the tip of the catheter. You will see there. We perform only a puncture, and then there we lean the tip of the catheter against the dorsum sella. And once we perform the fenestration, now we'll be we will advance the endoscope. And here we are advancing the endoscope into the interpeduncular cistern, and here we have the naked bacilla. Okay, during this transoperative procedure, we can have tachycardia, bradycardia, hypotension, or hypertension. It's very important we communicate this to the anesthesiologist in order to let us know, and we can stop the irrigation, stop the pushing backwards the brain stem, or withdraw the tip of the endoscope into the third ventricle. The reported rate of bradycardia during the fenestration of the third floor is 26 to 43%, depending on the series. And this is, as you can see, the most dangerous step in the performing third ventriculostomy. In conclusion, some serious complications are associated with endoscopic third ventriculostomy. The critical phase of the procedure is the perforation of the floor of the third ventricle, and a careful planning and execution of the procedure is mandatory, always supporting us in the MRI, especially the Fiesta sequence, and of course there is a learning curve. Thank you very much.
Thank you, Tenoch. That was a very nice talk. Moody, are you there?
Yeah. Yeah. There have been some questions to you, Tenoch.
Yes.
Yeah. Someone asked whether there is any risk of upward herniation from when you're doing the ETV. Is there a risk of upward herniation? I presume the question was from someone who was wondering whether the posterior fossa pressure can cause upward herniation. What is your experience?
Well, the experience really is that this procedure avoids the upward herniation. That's why we perform, instead of external ventricular drainage, the endoscopic third ventriculostomy. This allows us to wait until the patient is ready for the definitive procedure for the extirpation of the tumor. We don't have any experience any awkward herniation after third ventriculostomy posterior fossa 2.
And the other question somebody asked was whether you use a rigid or a flexible endoscope.
Always a rigid. I have no experience with a flexible endoscope.
Yeah, I thought so. And when you were showing the inter-hemispheric, the commissure, is there a risk of damaging it, or can you take it without any issues?
Well, we always try to avoid to damage the any tissue that looks like coherent. So we try to avoid that. But if we do it in the midline or paramedian line, in the most translucent part that we have seen, there is no complication afterwards.
And finally, someone asked, is there an ideal stoma size that you aim for?
Yes, usually it's 0.5 millimeter, 5 millimeters in wide. And that's the tip of the endoscope that I have. It measures 5 millimeters at the outer diameter. So that's why I always advance the tip of the endoscope into the stoma in order to achieve this size.
I have never seen.
Henry, you have a comment to make? Sorry, go ahead.
Yeah, one more question. So people say that there may be the diabetes insipidus. As for me, I have never seen any endocrinological sequelae. What is your experience? Is it really a possible situation? I have never seen.
Especially in patients with myelomeningocele, I have seen this kind of complications only transitory in the first 24 hours when the floor of the third ventricle is very thick.
Henry, you want to come in?
Yeah, just I want to make a short remark about the tough floor. So I never use for Gatti catheter itself. I always take a rigid instrument because, as you have shown, if the floor is firm, it may slide to one side or the other. And with a rigid instrument, you always hit the point where you want to go. So I always use the deck forceps. Very rarely, if the floor is very thick, I use a sharp pointed scissors to open it superficially. And then I take the balloon later on. And when I go down in the prepontine cistern and these arachnoid membranes are there, then I always use scissors to cut. I take the endoscopic sheath of the little otoscope, I can push the basilar aside, and then I take scissors to cut it, because in my experience, it's sometimes very difficult to open up these tough membranes simply by inflation of the balloon.
Thank you, Henry. Tenoch, any comment on that?
Yes, usually when we have prepontine arachnoid membranes, we, with the balloon catheter, not to inflate and deflate, only tear with the tip of the balloon, and then we advance the tip of the endoscope, and the membranes fade away of the tip of the endoscope. I find very risky in my experience to advance any sharp instruments into this membrane, because I had one complication of bleeding that went very bad. So I usually just do the blunt instruments. And for the perforation of the floor, I just when the balloon catheter, it's impossible to perform the floor of the third ventricle, I use a rigid endoscope, and it's been doing okay with that.
Thank you. There's a question from someone about the deck forceps. I suppose that's either to yourself or to Henry. Do you go ahead and just open it as freely, or do you just use the blunt edge of it?
So I use it to perforate the floor.
No,
the blunt
the
tip,
forceps. How wide do you? I suppose the question that was being asked was, how wide did you spread that forceps? Yeah.
Yeah, it depends on the size of the floor. Sometimes the floor is very wide, and you can open it very wide. And sometimes the floor is smaller, and then you open it not so wide. But usually I take not only this deck forceps, but at the second step, I take the balloon to make the opening wider.
And the question actually is, would you open it parallel to the brainstem, or would you open it the other way, like horizontal or vertical? Which way would you open the forceps?
It should open always parallel to the basilar, never towards the basilar. So if you have this forceps, it should be parallel to the basilar artery, that you open it from side to side, but not that one branch is pushing to the basilar, of course. And one major important information is that you have to open the floor always in front of the basilar. Never go behind the basilar tip, because there is the area where the perforators go to the midbrain. And one of our guys, it was in the early 90s, made the mistake that he blew up the balloon behind the basilar, and he ruptured one small perforator from the basilar artery. That was a technical mistake. It should not happen.
Yes, Sandy, you want to come in?
Thank you for all this. I think there's literally a world of experience here among all the presenters and the hosts. And I think what we're hearing is that everybody has at their disposal a set of equipment and tips and tricks. But I think for the general audience, it's important to remember that you're hearing from the masters here. That there really is a steep learning curve. So while somebody is comfortable with using a sharper set of instruments, that means you have incredible visualization. You know exactly where you are cutting and putting your instrument, and really having very intense and intimate knowledge of the anatomy, because there are certain consequences and complications that are not really fixable in this area. So I think no matter what your choice of instrument, if you have a choice or whatever you have at your disposal, it's important to understand those limitations. So if it's a rigid scope, you know, where your optics are, and if you're going to use blunt or rigid instruments, and then if you're going to use a flexible scope, what are your optics, and if you're going to connect it to cautery or not, and how you're going to manipulate that instrument. So I think there is a learning curve, and experience matters, and how you create that stoma with a Fogarty or not a Fogarty, or rigid or flexible instruments. It's remember that there's a learning curve. There's many ways to achieve the goal, but there are a lot of things that we can do to make sure it's safe.
Great, thank you. Schlomi, you want to comment? Thank you.
Yes, I just wanted to say that there is a potential move, which is to abort your procedure. It is an option. Do the abortion of the procedure before you make the hole in the basilar artery. And this is a judgment call. And when you do endoscopy, you always weigh the risks versus the benefits. And as you encounter a very rigid floor, or you lose your anatomy, or you don't know where the basilar artery is, or it's a complicated patient after an infection, et cetera, where the basilar artery is fixed with adhesions, there's always an alternative to an ETV, which is a shunt. So do it before you make the hole in the basilar artery.
Great, I think what, Salman, you want to come in?
No, I think Moody, please, if you would like to introduce Schlomi, so that then we have enough time for discussion at the end as well.
Fine, great. I think Schlomi gave us a preamble to his talk. It's great to see you, Schlomi. Great to see you looking well, and always a pleasure listening to you. I think that the 300 participants who've managed to sneak in and register, because there are some who are unable, are going to have a feast, because Schlomi is the professor of pediatric neurosurgery in Tel Aviv and comes with a huge amount of experience. He's been the president of the IFNE and really is a guru amongst all of us who do pediatric hydrocephalus work and pediatric neurosurgery work. Schlomi, it's a pleasure to have you on board.
Thank you very much, Moody. Good afternoon, good morning, good evening. Shabbat Shalom to all the 300 people who were lucky to get a ticket to this time event. It is really, really amazing to see how many people have interest. It's far more, I think, than any of our meetings. So You know, understanding that there is a large variability amongst the listeners between masters of neuroendoscopy, who have also heard my talks before, to people who probably have not participated or done an endoscopic third ventriculostomy, I elected also to give an introduction about hydrocephalus, about ETV, and then focus about ETV in infants. Well, it all started with the IFNE creation. This is the first meeting we had in 2001. Henry Schroeder is the current president. Giuseppe Cinelli is the past president of the IFNE. And basically, the IFNE serves as a forum for effective communication. This is what we're doing right now. We have to be careful not to be too much technology-oriented. We have to be disease-oriented. So it is more making sense to talk about hydrocephalus rather than to talk about ETV. We actually have to be patient-oriented, and we have to do actually health-oriented medicine. This is just a prefix. The IFNE had the last meeting in Florida, in Orlando. It was a celebration. The next meeting will be in 2021, towards the end of the year, and hopefully will be a joint meeting with the ISPN. This is the Tel Aviv Medical Center where I work. You're all invited to visit us. We're an international department. Well, I would like to speak a little bit about hydrocephalus, about general principles, and then about endoscopy. This is the box, which is probably the most important box in our career, in our life. And when we deal with children, it's the dialogue with the child, with the family, with the pediatrician, with the neurologist, with the insurer. And there's always a lot of talking to do with every patient, but it's more relevant when you have to deal with children. Everything is much more intense. And this is a paper we wrote in 2004, How to Get into Another Head Without Losing Your Own. For the sake of time, I will not go over this fantastic story of Huato, but this was published in Surgical Neurology 16 years ago. So how to perform an ETV without losing your own head. Then is technology. Technology is really, I wonder many times, does technology makes any difference? On the left is the Inca. On the right is our operating room 20 years ago. And this I took about 3-4 years ago, and I counted 25 computers, 19 monitors. We are a little bit too keen to play with new technology, and we have to control it. This is from Ashraf. When you get a new tool, you're first euphoric, then you go into depression, then you stabilize somewhere in the middle. Common sense is more important than technology, and low tech and experience and small details like how you position your patient, how you suture the skin are more important than any technological advantage you have. This is, by the way, the intraoperative MRI from Odin. Perhaps most important is to know which technology to hook to which patient and what biology. This is the first ETV I did in Israel a long time ago, 26 years ago, for this classical case. This is a 15-year-old with a tactile glioma, with triventricular hydrocephalus, with a great anatomy for an ETV. And this I did. This is a shunted patient. I did this kid when he was 1 day old, when he had head circumference of 42. He never had a shunt since then, shunt revision since then. So it's hard to choose. And I like the title, The Challenge of Hydrocephalus. This is a description from Vesalius. The ventricles were so big as to easily accommodate 2 glasses of Burgundy wine. And this is a book by Malucci and Skoros that has everything about hydrocephalus that you want to have. Imbalance between production and absorption that leads to ventricular megaly. This is the rule of thumb, and there are some exceptions to this. And I remind that the little piece in the fourth ventricle, a detached piece of choroid plexus is absolutely important because it keeps the absorption system alive. while we shunt patients, and this is why shunted patients who arrive with shunt malfunction are classical candidates for ETV. This is where the fluid is absorbed. So when you have a block here, somewhere in the tentorial incisura, it can be in the aqueduct, it can be in the CSF passages around the brainstem, you can do an ETV. So now you have a choice between ETV and VP shunt, not only between 300 different types of shunts that appear in the market. And this is how we traditionally used to subtype hydrocephalus, communicating and obstructive, when in fact all types of hydrocephalus are obstructive. When we say communicating, we mean that the obstruction is at the absorption site and not somewhere else. The real name, which is relevant to choose the right patients for ETV, is whether the obstruction is intraventricular or outside the ventricle. Or the other relevant question is the absorption system intact? And this is the reason probably that post-hemorrhagic hydrocephalus babies are not good candidates for an ETV. Also, following Abhaya's comment, the goal is not to achieve normal ventricular size. The goal is optimal neurological function. And Abhaya has taught us that the brain volume may have some correlation with the neurodevelopmental outcome. This is just a curious. This is a paper from, 40 years ago. This researcher who published in Science took children with severe hydrocephalus. 50 of them had 95% of the skull filled with water, and 50% of them had an IQ over 100. So he published this paper, Is the Brain Really Necessary? Well, just a curious. Shunts are okay. They're the bread and butter of pediatric neurosurgery. We know that. They have modified the prognosis of hydrocephalus from a lethal disease to a curable disease, but we know shunts. And you have several pictures. On the left is a completely missed ventricle. This patient, by the way, had 16 attempts in another hospital to hit the ventricles and came out hemiplegic from surgery. This is a shunt crossing to the contralateral thalamus. This is a shunt causing bilateral subdural effusions, etc., etc. So there are many jokes about shunts. We know we have different types of shunts. Nobody knows exactly which shunt is better than the other, but it took us a while to realize and admit. And if you looked at the curves that Abhaya gave in his talk, it took us a while to admit that about 30 to 40%, grosso modo, of the shunts fail in the first year, and then about 10 to 15% a year, probably until adulthood, and some say including adulthood. This is from the shunt design trial, comparing sigma standard and delta valves with not a big difference between them. And there are many jokes. This is from Salt Lake City. Hydro in Greek is many, and cephalus is revisions. It's not really true. So the best shunt is no shunt. There are infections, there's mechanical failure, there's seizures in shunts. Abhaya measured the seizure rate following ETV+CPC, but just to remind you that with shunts, you have probably about 1% per year which are joining the epileptic groups for people with chronic hydrocephalus. It just happens, it's accumulative with hydrocephalus. So basically, a shunt is a non-physiological solution. We know when we measure ICP in shunted patients, we see that when they are upright in vertical position, they have a significantly negative pressure in the brain. And we wonder, do we overshunt, and are we maximizing the developmental potential with shunts? This is from Alfred Aschoff. He's a big shunt lover from Heidelberg, who's been producing the best wake-up slides. And he said in Jerusalem, this is already a long time ago, in a deep German accent, in conclusion, natural is better than silicone. So this is probably true. So anyway, when endoscopy kicked in, the goal was no hardware. There was huge, huge enthusiasm with endoscopes. And the principle, you have a block here, you make a hole here, Also, when you have a block here, coined as FVOO, forced ventricular outlet obstruction, you can always also make a hole here. This is very relevant for children post-posterior fossa surgery who may have adhesions at the outlet of the fourth ventricle. And this is the case I showed you before, my first case from 26 years ago, classical case and the beautiful flow void after surgery. This boy never had any procedures since then, and his tectal glioma never grew. And this is how we do it. And for the sake of time, I will not go through films that you've seen during this course. Learn the anatomy, always learn the anatomy. And one thing in the whole anatomical view is to stress this point, just on the sides of the Monroe, is the internal capsule comes close to the border of the lateral ventricle. I've seen children become hemiplegic from the introduction of the endoscope, not from the penetration of the third ventricle. And this is the point, you have to be very cautious. Just go a little bit anteriorly than you think, and then pull your endoscope a little bit backwards in order not to hit this point, especially with ventricles that are not so big. Mind you, the trajectory is the most important thing. First important is where to put the barrel hole, and second is the trajectory. If you have navigation available, this can be fantastic. The tolerance for lateral deviation is smaller than you think. And remember, the trajectory is depending on your purpose. It's different for an endoscopic septum pellucidotomy than for an ETV. And look at the floor, the prepontine space on the left is a very tight prepontine space. On the right is a spacey prepontine space. And you can see a very, very beautiful floor and a lot of space in here. And on the left is a very tight here and here. You can do ETV in tight entries, but then the entry point and the trajectory becomes more important, because if your entry point is posterior, you're going to hit the clivus. If your entry point is anterior, you're going to be facing the basilar artery. Trajectory. And then the types of endoscopes. There are many, many types of endoscopes and how you do it. This is the OI endoscopes, and this is the MENOP. This is the LOTA. These are the flexible endoscopes. We do use flexible quite liberally. This is the Europan and the Vision Sense. This is the 3D endoscope that was sold from Israel to Medtronic. It serves mostly for basal operations rather than intraventricular operations. And all these tools, from all the tools, I just want to mention, this is almost mandatory to have a nice Fogarty catheter. Also mandatory is the DEC forceps or the cup forceps. They're terribly, terribly important to make a safe entry, as Tenoch has shown us very nicely. This is another tool, a Grutenhaus device. It's a sucker, basically. It was built with the idea to suck up the floor so as to make the hole away from the basilar artery. We use it now for colloid cysts. We do not use it for penetration of the floor. And then you can use neuroendoscopy also for posterior third ventricular. I just want to remind you, our paper from Journal of Neurosurgery, you have three options. One is to do 2 barrel holes for having ideal trajectory. The other one is to choose a barrel hole in between and compromise on your trajectory while pulling the foramina of Monroe. And the third option, which we have suggested, is to use a combination of rigid for the ETV and flexible for the biopsy of the posterior third ventricle floor. Use flexible scopes, get experience with flexible scopes. Sometimes you'll find it handy and you need to experience. They're not as intuitive as the rigids are. The flexible scopes, for example, are very important for penetration of trapped fourth ventricle through a synth floor or through the aqueduct. So what is better, shunts or endoscopy? This is again from Ashraf, who has blamed us that we look at ETV as heaven and as shunts as hell. Well, is this really true? And this is a comparison of different series looking at ETV and aqueductal stenosis in different places around the world. This is from Toronto, truly 35% success rate, and from Paris, 87% success rate. Well, everything in Paris works better. This is true for almost everything. And when Giuseppe Cinelli looked at the Paris and the Toronto failure rate of ETV, he saw that the major difference between these two cities were in early failures. And there are several reasons for early failures, but when we started to do the studies of the IFNE, we understood very early that selection and failure criteria vary very much between different centers around the world, and this has to be neutralized when you do multi-center studies. The nightmare of every neuroendoscopist. Following neuroendoscopy, the patient is well and can go directly to the ward, but the surgeon needs an ICU himself. Every ETV is different. Every ETV is stressful. Basilar artery perforation has been shown even from very, very good centers. We've had our first basilar artery perforation. I've presented it after about doing 1,000 of ETVs. It's a humbling experience. By the way, this girl is well now. We managed to control it. The hazards. Look at this case. I was centered on this web in the aqueduct here. I took her for an ETV. I will not show you the entire movie because of time scales, but look what I saw when I made the hole. God forbid, I made the hole posterior to the basilar artery. You're not supposed to make the hole here because here are the perforators between the basilar artery and the brainstem. And this happened because I overlooked the ectatic basilar artery. I was too much concentrated on this web. Would I have known that this is the situation in the interpeduncular cistern, I would probably not offer an ETV to this case. Sudden death after ETV exists as well, has been reported. Single cases, but important cases. Also shunts have sudden deaths. Remember that, and tell your patients that they are not cured of their hydrocephalus. They have to come immediately to the emergency room if they experience headache, vomiting, etc. So in the 1990s, ETV became a valid alternative to shunt implants. This is from Giuseppe Cinelli. The problem was that neuroendoscopy took over without any randomized study. There will never be a randomized controlled trial, RCT, on the classical ETV cases. And the other thing is that excluding aqueductal stenosis above the age of 2 years, all other indications for ETV are still questionable. So this is for John Garfield. You can teach a monkey how to operate. You cannot teach a monkey when not to operate. So there is a big question when not to do an ETV. Remember, those procedures, for example, the ETV+CPC, are heavy procedures with a lot of manipulation inside the ventricles. They have complications. Complication rates may be underestimated and underreported, including in the beautiful trials that come from North America. So in the IFNE, we started to produce papers, and this was the first paper about repeat endoscopic third ventriculostomy. And in this paper, we had the advantage of recruiting 20 patients from 4 different centers around the world. This was beautiful, and we showed 65% success rate. So when ETV fails after an initial success, you can offer the patients a repeat ETV. It is an option which works for about 2/3 of the patients. Then we became more ambitious. We look at ETV following patients who had CSF infection or hemorrhage. And here we took 101 patients from 7 centers that are listed here. And what we found in these patients who had either infection or hemorrhage, or both infection and hemorrhage, was that the overall success rate was about 60%. But once you had both infection and hemorrhage, only 1 in 4 will benefit from an ETV. While we did this study, this was the third study, the INEBS, about the validity and the accuracy of neuroendoscopic biopsies. And here we had 13 centers with 293 patients, very nice results, because we had 78 patients who had endoscopic biopsy and then had an open biopsy, so we could compare the endoscopic biopsy to the gold standard of the open procedure. And we found that 82% had a complete match, and significant difference occurred in more than 10% of the cases. This is true, by the way, also for stereotactic biopsy. This was published in Journal of Neurosurgery 7 years ago. So while we did these studies, we realized that in parallel to the study patients, there were many other patients who underwent ETV, over 1,000 patients in the 7 centers that participated in the post-infection, post-hemorrhage study. And Abhaya Kulkarni decided to follow up on this huge number of ETVs. This is really, it brings you to statistical power. He took the over 1,000 ETVs, he took over 600 shunts from the shunt design trial, and for the first time, he designed the ETV success score. This is Journal of Pediatrics. This is becoming a standard. The ETVSS should be used by you when you face a family and the family is asking you, what are the chances that the ETV will work? It's a basis, it's simplistic, but it is still something. What happens in infants? In infants, the potential benefits of ETV are large. And if you look here at the survival curves of shunts, you see that the shunt survival curve in infants is age dependent. The younger you are, and if you're a preemie, the chances that your shunt will malfunction quite fast are higher. Is it more dangerous to do an ETV in an infant for the short term, during the operation, intermediate term, leaks, infections, and for the long term? Are we converting an active hydrocephalus to an arrested type? This is really the question we need to ask ourselves. What is in the literature on ETV in infants? Again, Paris, everything is fantastic in Paris. UK, 30% shunt independence. Tel Aviv, 55% shunt independence. Well, different results. Look at this example. This is a baby who had an ETV when she was an infant. She continues to be on the 99th percentile. You see her forehead, fontanelle on the full side, mild delay continues. Parents are very happy. She had 3 LPs. On MRI, she has a nice flow void. So, is she a success or a failure? Have we transformed her to an arrested type of ETV? And look at this kid. At 2 months with aqueductal stenosis, he had a VP shunt by parental preference. 1 year later, he had a block and a revision. Then he had another block, and then the parents agreed to perform an ETV. The ETV was successful, and he's wonderful for 12 more years. Just a wonderful, perfect kid. You see him here, and you see him here in his bar mitzvah. He's wonderful. So maybe better is to start with a shunt and then convert it to an ETV at the later stage. So on the right is just ETV. On the left is a VP shunt converted to an ETV. And in the center is the boy I showed you before, who got a shunt only at day 1 with a head circumference of 42. And he's just wonderful, this child. What is better? This is really the challenge. This is the reason we started the IIHS years ago, the steering committee with Spiros Gores and Abhaya Kulkarni. I could not do this study without them. This is a multi-center international RCT on the role of ETV versus shunt in infants with obstructive hydrocephalus. And in this study, we had a wonderful advisory committee. We had a monitoring committee with Doug Kochman and John Castle. And we asked participating medical centers to have a strong neuroendoscopic orientation, to have experience with infants, but mostly to have resources to follow the kids for at least 5 years. We took newly diagnosed obstructive hydrocephalus with ventricular hydrocephalus, full-term pregnancy. So the infants with post-hemorrhagic hydrocephalus, the preemies, are excluded from this study. And again, ability to follow for 5 years. This is how we did patient randomization. The patients went to under randomized process, but also we recruited patients according to parental preference. So this is called a comprehensive cohort design. This was designed by Abhaya. We ended up with 4 groups: randomized shunt ETV, parental preference shunt ETV. But the primary outcome measure was the neurodevelopmental score at 5 years. This was revolutionary, and I'm very happy that Ab and the French in North America are trying to do it for the ETV+CPC. This is extremely challenging. What Abhaya did, he produced a 5-year outcome battery. The battery is produced by 5 tests. Some of them are done by parents, some by professionals. And since we had patients from many countries around the world, these tests were translated to 8 languages and then reverse translated to make sure that they are really same as the original. The secondary outcome measures were all the variables that we traditionally take, like number of operations, morbidity and complications, shunt freeness, etc., etc. This was the time frame. We started it, well, this really took a while. In 2004, we got the final results only 2-3 years ago. So we recruited 182 patients from 27 countries. You can see them listed here. 158 patients were available for analysis, and you see how they were dispersed between the 4 groups of ETV, shunt, controlled, randomized, and parental preference. And I will sum up the results for you in a way that you can remember. You see the comparison of the 2 groups is very valid, and most of our children were below 3 months of age. So this is really an infant study. The perioperative complications between shunts and ETV were not really different. There were more CSF leaks, well, not negligible in the ETV group. This is, by the way, a technical exercise, how to prevent CSF leaks in ETV, but overall, there were no morbidity or something that should prevent you from doing one over the other. This is the ETV versus shunts in infants with aqueductal stenosis. This is for all patients, and you see that the shunt group did better than the ETV. This is ETV 66%, overall shunt 83%. But if you take the infants over 6 months of age, you see that the survival curve is similar, 80% for both groups. If you take the infants below 6 months of age, the shunts are doing far better than the ETV, as you can see here, 58 compared to 82. This does not mean that ETV is not an option. It's an option, but at least when you sit with the parents, you tell them the data so they know and they can take a decision. We want to look at the full half glass rather than the complication side, and we go for it. Well, nice. So if you look at ETV versus shunts in infants with aqueductal stenosis, when corrected or adjusted for difference in age and history of hemorrhage or infection, the risk of ETV failure was about 3 times higher than of shunts. Relatively low morbidity for both options, high treatment success rate. Overall, below 6 months of age, there is a difference. Above 6 months of age, quite similar numbers. In ETV, in infants below 6 months of age, ETV is an option, but should be discussed with the parents. Then we reach the neurocognitive outcome measures. I will run these slides because of issue of time. This was really a major effort to get these numbers. We checked our infants at 1 year, at 3 years, and at 5 years after the study. And I will take you to this is for 1 and 3 years. And at 5 years, when you look at all these tests, there is no difference between shunts and ETV in terms of neurocognitive performance. What about ventricular size? Well, again, we discussed this. The ventricular size did not significantly affect the neurodevelopmental outcome at 5 years, and this is in line with what Abhaya has told us in the ETV+CPC studies. The limitation of the IHS was a mixture of randomized and parental preference. Assessment of outcome was not blinded. We did not measure brain volume. It's a small sample, and it is effective and reliable only on infants with aqueductal stenosis. But at least for aqueductal stenosis, we know that the neurodevelopmental outcome is very, very good. And this has significance when you provide prenatal consultation to parents with a clear-cut aqueductal stenosis fetus. So these are the conclusions of the IIHS. No significant difference between neurodevelopmental outcome in 5 years. These are the 3 papers published on this for anyone who wants to read more about this study. Thank you very much.
Thank you very much, Schlomi. I think I'm sure there's going to be a huge amount of questions, but some of the ones that people have been throwing at us, Christine gave us 2 questions. Maybe you can, Christine, go ahead and ask your question to Schlomi directly. Christine, are you there? Okay, Honor? Honor, go ahead. Honor, is that Honor Kopke? Somebody's raised a hand. Honor.
Just 1 second, trying to unmute, and for whatever reason can't. Imad, can you please unmute Honor there?
Sir, I don't know. I'm unable to unmute him.
Yeah, same here. Honor, you can write your question. Sorry, we can't unmute you for whatever reason. So there is Kesar Haroon, he's asking a question, a great presentation. In many books, the authors suggest at least 1 centimeter cortical mantle for CSF diversion. What is your suggestion? Schlomi?
You mean that anybody less than 1 centimeter should be shunted or should be ETV'd? Can you specify what is the question?
The question is for CSF diversion, the minimum that they want to have a mantle of brain is 1 centimeter. Is there any logic behind it?
Well, it's an old school parameter. I remember we used to abort fetuses based on their cortical mantle. I just want to say that I've seen many babies who have such a thin cortical mantle, and after you shunt them, the cortical mantle broadens. So I think that other variables are more important than the cortical mantle.
Okay. There's a question from Christine, is that use of endoscopic ultrasound to help penetrate the floor?
I don't have experience with that. I think what you see with your eyes is more important than any ultrasound.
Okay. What do you suggest about patients having very large head size and thin cortical rim, ETV or VP shunt?
Well, it's a good point. Those patients with the huge heads and huge ventricles will invariably have subdural hematomas after shunts. Even if you put the most restrictive shunt that you have, if you put shunt assist with antisiphons, they will drain a lot upon vertical positioning. So in these patients, I would try very hard to avoid a shunt. So if their anatomy is suitable for an ETV, fantastic. I would even offer, which I did a couple of times, ETV+CPC to this group. I usually leave an Omaya behind just in case, but trying very hard to avoid a shunt.
Okay.
There's a question from Dr. Imad and another one from Dr. Guido. Dr. Imad, would you want to ask your question?
ETV, fantastic. I would even offer, which I did a couple.
Dr. Imad?
Shlomi, can we unmute?
Yes, I asked if there is a need to suture the dura after we do the ETV. Should we suture the dura to avoid CSF leak?
Tenoch, would you like to answer that, please?
Yes, I never do the suture of the dura. What I do is to put a plug of gel foam in the corticotomy and it close very tight the gallia and the skin. I never have had the need of close the dura. And in my experience, if the patient presents with CSF leak after more than 7 days after the third ventriculostomy, this is a patient which needs a redo of the third ventriculostomy or to put the shunt in to control the hydrocephalus.
If I could add, I think for cases like that, it depends for me on how old the child is. So for infants, I actually do try to close the dura, so I'll do a linear durotomy, sometimes even a small mini craniotomy as well. So you close the dura tightly and put the bone flap over it to get a very good closure. But I only do that for infants. If it's an older child, I wouldn't bother with any of that.
There's more question for you, Abhaya. Do CPC cause injury to choroidal arteries as a complication?
So you will, by nature of what you're doing, you do cauterize the vessels within the choroid plexus. That's an intent of the procedure. The issue is what the impact that is on surrounding brain. Now we image all these patients postoperatively with MRI in the North American setting. From the study that I showed you, you could see that there is an incidence, it's not zero, of having neurological deficit after this procedure. So it does happen, it's rare, but it can happen. So if there is any more subtle injury, we'll find out when we look at our neuropsychological testing, but we haven't seen certainly a high incidence of stroke, either venous or arterial, as a result of choroid plexus cauterization, but there is a small incidence of having some, at least temporary neurological deficit after. It's rare.
We have four questions from Dr. Guido, Dr. Marco, Dr. Hussein, Laura, and Bu Yusuf. Maybe in that order you could ask your questions, because otherwise it's going to carry on. So Dr. Guido. Is Dr. Guido unmuted? Yeah. His microphone is not working. Okay. Dr. Marco, maybe you can ask your question while Dr. Guido types his question. Dr. Marco?
Marco, okay, please raise your hand so that you come up on the screen and then we can unmute you. They have to just raise their hand so they'll come on the top.
Dr. Guido. Okay, he's asked if, can you see the full question? Because I can only see part of it.
I've asked if any of the presenters have experienced an ETV treatment in case of slit ventricle syndrome. Abhaya? Would you treat ETV with slit ventricle?
Yeah, so I haven't used it that much. I've generally avoided in true slit ventricles because of the technical difficulties, unless I can get the ventricles up at least slightly. So I've had limited experience in using it for that scenario.
Okay, so there is a question by Kenichi that any experience ETV with stenting?
Yes, maybe I answer. Ulrich Tomala has, I don't know if he's here, Ulrich, but he has described, and we've followed his experience. Occasionally, we leave after the ETV, we leave an Omaya with the catheter going through the ventricular floor. We do it when we feel the ventricular floor opening is small and scarred. So we do it in that way. Just stenting and leave the stenting there, we don't do, but as part of Omaya can be done.
Okay, so there's again question about duroplasty. Would you do duroplasty? Would you use any kind of glue or gel to close to avoid CSF leak?
Well, if I may say, Ben Wolf used to put one suture. I remember one suture over the dura. I think it's a vicryl at the end of the procedure. So it was very neat. I never closed the dura. It's just not. It just doesn't close. I do leave a little piece of gel foam. I don't know if it helps. I do not lose glue. What I do is to insist that the skin incision will not be over the burr hole, but a little bit in front so that the pulsation, if there is a continuity of CSF, will not hit the suture line.
Bu Yusuf, you had a question. Bu Yusuf, you had raised your hand.
Thank you very much. Thank you for this very nice presentation. It's not a question, it's just a comment to give you our experience for more than 3,000 endoscopic procedures, a proposal of algorithm, like you see in this picture, whatever etiology or age, we perform first ETV when the infant is under 1 year. We perform ETV and CPC. If there is failure, we redo ETV, and we have 50% of success rate after a redo. If there is a failure, we can ask at this moment to put a shunt. The worst results are in infants inferior to 3 months, and also post-hemorrhage hydrocephalus. Thank you. What do you think about that?
Hussein, do you have a question? I think you've been waiting.
Sorry?
There is a question from Hussein, or is it Hussein?
There are two people with the same name in here. So unmute one of them. Al-Hussein, are you there?
Okay, thank you for this great presentation. I just want to ask, in cases of difficult perforation, can we use anterior third ventriculostomy instead of the floor of the third ventricle, or can we use such kind of cautery or something in the in front of the instead of the balloon or the blunt instruments? So what about the cauterization or shifting from the floor of the third ventricle to go to the anterior wall of the third ventricle?
You mean the lamina terminalis?
Yes, yes.
Yes, maybe I will answer that. Well, you can do buzzing on the floor if you do it short, without pushing, and with not too much current. We do it quite often. And if you want to be 100% sure, you can do the buzzing on the posterior clivus. The danger with that is that sometimes you will penetrate the floor, but you will fall to the subdural space and not to the subarachnoid space. And after you are in the subdural space, it may be very clumsy to open the arachnoid because you don't have a good angle, but it is something you can do. Opening the lamina terminalis can be done, in my opinion, only with a flexible scope, and you need a lot of experience to do it. Ben Wolf is doing it quite often.
Edgardo, you had a question? Edgardo?
So we have Rashim Kathiria, sorry. Can you please ask a question?
My question is like when the floor is sometimes it is very floppy, like it is a floating floor. So how to make a perforation in that sort of floor?
Shlomi, you want to answer
Am
that?
I audible?
Yes. Are you referring to
Yes,
floors
you are.
that are very floppy? They move, and when you push in something, they move inside with your tool. Are you referring to this type of floors?
No, actually, like initially the floor looks like okay, but after some time it started floating. So how to fix that floor, or like how to make a perforation in such a floating very thinned out?
Yes, well, I'm not sure if I understand, but if you mean the floors that move up and down a lot, like a curtain, during the procedure, before the procedure, yes, they may be challenging. And if you can shift a tool and just by pushing, it's okay. Sometimes I have grabbed the floor with a forceps and torn a little piece by pulling up, and then it becomes easier. But this is difficult to generalize an answer to this question.
If I could add, I think that the scenario that he's referring to, you see after you've done a decompression, you release CSF with your endoscope, and that's what's causing the floor to balloon up and be floppy. So in those situations, I'll use irrigation, and you have to do this very carefully, of course, but to stop the egress, the escape of CSF. Of irrigation. So you have to be very careful when you do that, because obviously you can get raised intracranial pressure, but usually that creates enough buildup of fluid in the ventricle to stop the floppiness of the floor and brings it back down to the position that you would have seen right at the beginning of the surgery.
Okay, brilliant. I think we move on to multiple choice questions. If there are any more questions, please type. And in the meantime, look at the multiple choice questions and their answers that you have filled in. So can we have a look at that, please? Imad, can we share multiple choice questions with us, please?
So is it visible? I have shared it.
Nope, can't see them.
Hello?
Can you redo them, please? So there's a question.
One second.
From Lauren. Lauren, would you like to ask your question while the screen is being set up?
Yes, Lauren.
Hi. Hello, friends of Africa. Thank you for the talk. Just two questions. What features can you look, radiological features can you look for to see if there is ETV patency? And the second question is there a weight cut-off for a minimum weight cut-off for a patient to go to get a CPC?
Sorry, Abhaya, you want to take that?
So actually, I could not hear the. Salman, did you hear that better than I did? Because I couldn't understand.
I think it's probably about radiological features that you need to see after you've done an ETV.
Radiological.
Yeah,
I see. Yeah.
Agency. Yeah.
Right. So, I mean, we look at a couple of things. So, you look at, obviously, the ventricle size doesn't change tremendously, but you can look for subtle evidence of changes, positive changes in the ventricles, like reduction in some of the periventricular edema, increased appearance of the sulci and prominence of the sulci that you didn't see before. I also look very carefully at the configuration of the third ventricle. So if there was any bowing out of the third ventricle, even if it was subtle, I'd like to see that improving on the post-operative image on the sagittal MRI. At the stoma itself, you look for evidence of a flow void. You don't always see that. I think where it's most useful is when you've seen it early and then you lose it at some point in follow-up. To me, that's a relevant finding. And these days with the CISR Fiesta imaging, I think you can also look for evidence of the discrete defect itself. You should see the hole in the floor of the third ventricle.
That's brilliant. Thank you.
Hemant has a question. Hemant, go ahead.
Sorry.
Hello?
Please go on.
Yeah, I just wanted to know if you have faced a problem of abandoning the ETV because of poor visibility, what I usually call it as smoky ventricles. When the head is too large, sometimes when you push your endoscope inside and it is all, smoky something, and then it becomes difficult. You give a lot of irrigation, still it is not visible, and it is like something like clouds moving inside the ventricles.
Shlomi, you want to take that?
I've seen that, and especially in post-hemorrhagic situations, high protein level, smoky, as you say, usually with enough rinsing, it clears up, but it can happen.
Okay, we are going to go to our multiple choice questions. We have got 5 minutes to go before we close up. Abhaya, you want to take these questions that you put in there, or shall we go to the responses directly? Let's go to the responses, Imad. And take us down there. Yeah, thank you. And Abhaya, would you like to take these and see how people have done?
Yeah, so here what I was alluding to was the data from the HCRN predominantly, but also Ben Wharf's data looking at the ideal candidates for ETV+CPC, at least in the North American setting. And again, I've specified that compared to what we've seen in Uganda. And so the correct answer is myelomeningocele older than term. So we know post-infectious does poorly because of the scarring. The IVH or prematurity, they've done very poorly up until 6 months of corrected age or beyond. So when they're younger than term age, it really doesn't work well. And similarly with other etiologies, unless they're at least about a month old, the success rate is very poor. So out of these, the best group is the myelomeningocele older than term. They seem to actually do quite well with this.
Okay, let's go down to the second question. Imad, can you go down to the second question? Thank you.
So here for the randomized trial, the results really in all respects showed no major difference between ETV, CPC versus shunt. So cognitive outcome was no different. The failure rate was not significantly different. The brain volume as well was not significantly different between the two. But what was different is the obvious thing, which is that shunts reduce CSF volume better than ETV+CPC, as we see anecdotally, and here we've shown statistically that the ventricles get a lot smaller with VP shunt than they do with ETV+CPC, but that doesn't necessarily mean the brains are any bigger.
Okay, next.
And then, yeah, the final one for ETV+CPC is, which of the predictors, which is not as a predictive factor. So age of the child is, extent of the choroid plexus that's cauterized that's been shown in Ben Wharf's work as well as in our work in North America and Uganda. And the presence of prepontine scarring as well, very important, because if you can't clear that properly, then that portends very poorly. So what hasn't been shown is the size of the septum pellucidotomy that you've created. So I think people might have misinterpreted some of these, but this is the right answer. So the size of the septum pellucidotomy obviously doesn't matter. That's just the access point to get to the contralateral ventricle.
Okay, brilliant. Let's go down. And this is Shlomi. Shlomi, you want to take these, please?
Yes, 51.3% were correct. That's not bad. That's no bad. Well, I'm not familiar of a study showing that 4 is better than 3 is better than 2. Instinctively, bigger holes should be better, but this says has been shown, so it has not been shown. Opening of Lilliquist is mandatory. Yes, it is mandatory. Never perforate the floor with a current is not true. Sometimes you can use short currents. Always use large scopes. No. Okay, anyway, people got the idea.
Okay, next.
I think Carla was asking what size of Fogarty do you use regularly, Schlomi?
We use the figure of 8 Fogarty. I'm not sure, but if you send me a private mail, I will send you the package picture. Okay, ETV.
You got that, Carla?
Is that okay?
Yes, I think Carla's seen that. Yep.
Okay, good, thank you. Okay, ETV is superior to shunts. Well, certainly not always. Only below 3 months of age, no. Only in post-hemorrhagic hydrocephalus, no. And yes, seems equal. So 2/3 of the people answered correct. Not bad.
Okay.
Okay, look at that. Okay. The use of navigation can be useful. This is true, over 50%. The place does not matter as long as the trajectory is good. No, incorrect. The trajectory cannot be good if the place of the burr hole is incorrect. And temporal burr holes, oy vey, no, not. So anyway, more than 50% answered correctly. Very nice.
Okay, brilliant. Adrian has just answered that question for you. He's saying it's 3F size balloon, which is equal to 5 millimeter. That's for Carla.
Okay.
Okay. Henry, are you there? Is Henry sleeping?
I'm still awake. I'm just listening to the outstanding presentations.
I think it was brilliant.
Yes, and I want, as usual, I want to thank all the faculty for the outstanding presentations. I think we learned a lot today. Salman, I want to thank you for hosting us again. And of course, I want to thank all the participants for the interest in these webinars. Yeah. And I also want to invite them for the next week. We will talk about arachnoid cysts.
And your guest speakers next week we have?
We have Samer, we have Joachim Oertel, Samer El-Baba from Orlando. And then we have Samuel Zimberg from Sao Paulo about the suprasellar cyst. So I think it's going to be a good event as well. I invite everybody to join us next week.
Okay,
now I want to wish you a nice weekend.
Thank you.
Thank you, everybody. Moody, would you like please wrap up? You're our moderator.
I think it's been a huge amount of learning for everyone, including those who've been doing a little bit of ETVs around. So thank you very much, Schlomi. Thank you from Mexico. And thank you, Abhaya. Tenoch, it's been a brilliant talk. And Salman, as always, you're a star. Thank you very much.
Thank you, guys. All of you are brilliant. And we'll hope to see you next Saturday. And we'll continue to enjoy all these talks. Thank you all. Bye-bye.
Thank you.